Hello everyone, and welcome to the CVI Foundation webinar. This is an exciting night tonight. We have three very experienced presenters talk about the most instructive PCI cases that they had during the last year. So we kept it very broad to cover a variety of topics, and as you'll see, there will be a lot of things to learn from these cases. This is for everyone. There's CME. You can go to the CV Innovations website for CME. And then the faculty today, we have Dr. Jarrod Frizzell from the Christ Hospital in Cincinnati, extremely experienced operator doing high volume PCI. And then Leah from Vanderbilt University, also extremely experienced and very good operator, and Yader Sandoval, who is my partner at the Minneapolis Heart Institute, doing a lot of complex PCI, a lot of CT-guided PCI as well. So all of them are great presenters, and we're very excited to learn from them. Before we start, I would like to thank the sponsors, which are Abbott, Medtronic, and Shockwave. Really appreciate their support. And without any further ado, we will go on to start the webinar. At the end, again, you can go onto the website, and then you can get a CME for this. So without further ado, we'll start with Jarrod Frizzell. So Jarrod, thanks again so much, and super excited to learn from you and see your case.
Thank you. Thanks, Manos, for having me. And I want to really thank our sponsors as well. Let me get my screen going here. So I really appreciate this offer. I feel like that I really learn something every week, and even every day in the lab, there's something else that I'm still discovering, regardless of how many you do, there's always something else. So I'm going to share a case that happened this year that's really personal to me. I think there's a lot of points out, but especially there's some things that I've never seen before. Here's a background. So this is a 71-year-old man. He's got prior CABG. He's got all the stuff as usual. He was initially presented with a non-STEMI. He was found to have a ZF had dropped by echo 35%. He had a cath. I'm basically not going to show the whole diagnostic cath. I'm going to focus on what I did. But he had CTOs of all of his vessels, except that his graft to a diagonal was patent, but had disease at the anastomosis, both going toward the diagonal as well as toward the septum. And he had a Allina that was patent to an extremely diffusely and small diseased LAD. After that cath, he was told, there's nothing we can do. I'm sorry about your angina. They upped his medicines. He came for a second opinion. He had a cardiac MRI that showed his EF was 29%. And basically, he just had the septal and diagonal territory that was viable. EP told him to stay on medical therapy for at least another couple of months, and they'll reevaluate his EF and consider whether or not to do an ICD. So I started my case. My plan on him was to go after his native diagonal through his proximal LAD CTO, since that was the only viable territory. And there was disease at the anastomosis going both directions. These are my setup shots. I'm not really laying out the anastomotic lesions as well, because that's not my focus here. The goal is to get this proximal LAD opened up into this diagonal. So there again, you can see it's kind of a fair amount of distance. It's probably about 20 millimeters or so, very diseased here. And according to MRI, essentially this diagonal, which has some disease here as well, is viable, as is this septum, and then not much else.
Perfect. And then Jarrod, if we can ask, so obviously looks like very complex. So here you have the diagonal feeding the vein graft, filling it, but then I guess the septal doesn't get enough because of the lesion, and the diagonal has the distal lesion further down, right? So
correct. There's like a lesion here at the anastomosis, as well as this distal lesion, and then there's a lesion right here in the proximal portion of the diagonal.
So you're concerned that if you stand across, then you might lose the other branch, and that would be obviously very bad in someone as fragile as he is.
Yeah, exactly.
I don't know, Leah or Yader, any other thoughts on how to do this? I know this is obviously a super selective, complex case, and I love the ADP as well. I think that's a great way to start.
Yeah, I agree. I think ADP is really important in this guy with severe LV dysfunction, kind of coming in with this NSTEMI. So agree with that. Yeah, I agree, Jarrod. I would probably go retrograde here through this vein graft, because you have direct access to your diag, and then probably set up for some like retrograde dissection reentry, which I'm assuming you're going to set up here with your EBU in your left main.
Mm-hmm. Yeah.
Jarrod, remind us of hemodynamically stable support. Was that a question or no?
Support, you know, I checked the EDP beforehand. It was okay. His blood pressure was 140/90 starting out. And so this is one that, you know, I felt pretty comfortable proceeding without hemodynamic support. I mean, despite the fact that he does have a low EF, he seems to be fairly well compensated. And his presentation, initially during the diagnostic, they did a right and left. And surprisingly, his cardiac output was normal. His wedge at the time was about like, you know, 14, 16, something like that. So nothing too terrible for that. He didn't seem to be decompensated from a heart failure standpoint, but great question. And it's really common for me I almost always will check an EDP. I don't often do a right heart cath, especially if they've had one either during that admission or recently.
Perfect. Yeah, thanks so much. Again, very complex case. Looks like you had a blunt proximal cap. Length is intermediate, but you have a nice retrograde option. So perfect.
Yeah, exactly. So I started with retrograde, and I'm going to kind of bust through the case relatively quickly to show you a lot of things here. So I got retrograde, but the distal cap here was actually pretty impenetrable to even stiffer wires, such as a Guy X3. Obviously, you lose a lot of push whenever you come around like a really sharp angle like this. I did a Carlino to try to frack it, and it didn't work. So I got antegrade with a wire pretty easily. Just slipped down, but you can see the wire here isn't really in the right spot. It didn't look like there was an overt perforation or anything like that. I didn't really follow it too far with equipment. So I decided to go with a little bit of a safer option and do a base up here. So I've got a balloon inflated in the proximal LED, kind of heading out a really small diagonal. And antegrade here, I've got Corsair Pro, and then you see a Mongo wire that's kind of going around the balloon, getting started with the dissection. And so I feel comfortable because I'm starting the dissection in the vessel, stay within the architecture, and then I'm able to get a good knuckle going antegrade. So this resolves that ambiguity. I'm confident about where I am. And what I actually end up doing is I take the knuckle down past my retrograde gear. It follows very well. Again, because it's a knuckle, it starts in the vessel. It's going to stay in the vessel architecture. I feel good about this in multiple views. I end up doing an external cap crush. So because the distal cap was impenetrable, I delivered a balloon over that knuckled antegrade wire and ballooned this, and now I was able to easily get a Mongo wire to go retrograde now. And I pretty easily was able to slide that into the antegrade guide extension that I already had set up. So now I've done, you know, what I think is the hard part of the case. I've already kind of completed my reverse cart. The next thing to do is to deliver a wire and get it to go down into the diagonal. So after ballooning into that diagonal, I was able to deliver IVUS at least this far, which showed it confirmed I was in a dissection. The distal cap was, you know, really well cracked, so I wasn't concerned about, you know, being able to do. I didn't think that I needed to do additional calcium modification on the way back. I didn't show the wiring of this diagonal. It was a little bit tricky, but not too bad. But then I put a balloon there, and you can see there's a sizable waste right at that other anastomotic lesion there. One thing that I did not necessarily expect was how very sensitive he was to anything to do with this diagonal more distally here. As soon as this balloon went up, his pressure was started out at about 140/90. His just went down. It dropped like a rock pretty quickly within about less than 10 seconds. He went from a pressure of 140/90 to a pressure of about 90/70 pretty quickly. He would rebound fairly quickly as well. But I was really surprised about what he started at, how sensitive he was to this. With a non-compliant balloon, I was able to pop that open pretty well, and I felt comfortable with that. And again, I could not do very long balloon inflations at all. I paid attention to the pulse pressure, I paid attention to the overall pressure, and no inflation here was longer than about 5 seconds. He was completely asymptomatic as well, and his ECG didn't budge at all. It was really the pressure. So because, he was that sensitive, I would kind of independently do angiography to see what was going on down there. One of the things that you'll see in a little more detail later after I stent this is it actually looked like he had a bit of a myocardial bridge in that diagonal. I don't know if that played into a role, but you can see there's a little bit of squeezing going on right there. So anyway, I get it opened up. I'm able to stent. I'll pop through a lot of this part. I'm able to stent from the left main into that diagonal. I also opened up that distal lesion down there. It looked good because I was worried about competitive flow.
You do anything there?
I ended up coiling that diagonal. Down distally, I just down here. It was actually inside of a stent already, so I just did a high pressure NC balloon inflation down here with
Perfect. And then there's one person asking about what was the reason of hypotension, and I presume it was just ischemia because he didn't have that much myocardium that was functioning, and now you're making the myocardium. Is that your?
That's also my presumption. Yeah, because if you look at the MRI, essentially the viability was the septum and this diagonal, and so in some respects this was a last remaining vessel sort of scenario. Even though in the big scheme of things, it's not that much of his heart muscle. If you look at his actual viable myocardium, it represents a fair amount. I don't think, other things you think about kind of with ischemia is whether or not you're causing like ischemic MR or something like that, that can also tank your pressure pretty fast. I think the fact that he started out fairly well compensated with an EDP of 15 and a normal blood pressure and a very recent right heart cath that showed normal cardiac output index was the reason why he was able to bounce back fairly quickly. If he wasn't able to bounce back or if his hemodynamics was different, this is one that I would think about putting in some mechanical support to help offload that. The other thing you can sort of appreciate on this too is that little bit of a squeeze there that I suspected was probably a myocardial bridge. I don't know if that played an effect of this or not. I was not able to get IVUS to go all the way up and around this bend. And I just plain didn't think to IVUS down that graft as I could have.
Jarrod, if I can jump in, I mean, you're very experienced operator, and you can probably go through this very fast. But there's probably like a checklist, right? Like you're going through, as you alluded to, ischemic MR, pushing the guide, your regurgitation, access, perforation, and because you don't want to discover too late that there was something amiss. So I don't know. I guess you alluded to the pulsus paradoxus, but an echo, doing just a checklist that you're not missing anything.
Yeah, so I don't really do an echo unless I suspect a perforation, stuff like that. And it wasn't really pulsus paradoxus, it was the narrowing of the pulse pressure. And to me, if the pulse pressure narrows, that means that the stroke volume goes down. One of the things, if you start dealing with unexplained hypotension, you're right, I have a mental checklist I do. And one of the first things I do, since most of my interventions happen to be on right coronary arteries and I use aggressive guides, is I actually tuck back on the guide a little bit, because I feel like one of the very under-recognized reasons for unexplained hypotension is propping the valve open and causing wide open AI. And if somebody doesn't have a lot of reserve, they do fine until they don't. Because this was very tightly correlated with the balloon inflations, the balloon goes up, you have, up to 10 seconds or so before he really starts getting in trouble. That to me really tied it with ischemia. I was giving intermittent puffs through the graft to make sure there's nothing else crazy going on. But you're right, having that mental checklist and being prepared. And if you're going to do a challenging case, whether it's something like this or something else, then it's really important for you to sort of think about those things in advance. And the more you do it, the more of a habit it becomes, and you don't even think about it, which is good, because a lot of times you don't even have time to think, you just have time to act. That's a great point. By the time he left the lab, go ahead.
No, Jarrod, I was just saying, I just want to emphasize, you said that you de-escalated your wires from Gaia's to knuckling polymer jacketer wires, which just makes all of this a lot safer. And so probably your concern for perfs probably went down a good amount of bit because of that. And then my other question is, after you stented the diag, did his pressures rebound?
Oh yeah, like anytime the balloon was deflated, his pressures rebound.
Yeah.
And I make sure to give, the faster they go down, the more time you need to make sure to give them to recover. I feel like one of the problems that people may have in these sort of things is they get in a mindset of, okay, I gotta hurry, I gotta hurry, I gotta hurry, I gotta bust through this. And so they end up going up and down and up and down and up and down, thinking that makes them faster, when instead effectively that prolongs the ischemia. We know from old studies, I got a really nice one that I like to show fellows and stuff that looked at hemodynamics during angioplasty that was done in the late 80s, where they would leave a balloon inflated in the Prox LED for minutes at a time. And what they found is that you reach steady state after about 60 seconds. However, to fully recover both systolic and diastolic function, it could take several minutes afterward. So it's one of those things that slow is smooth and smooth is fast. Just take your time, be patient. It's not a rush. And that's exactly what I had to do with this guy. His pressure would come down with the balloon inflations, and I would stop, take a break, let him take a break, and just sit there and just wait. And even after it normalized, because it would normalize fairly quickly, I knew that in order to become fully normalized, that it's going to take a lot longer. So patience is definitely a virtue in one of these things.
And then
by the end of this
question,
case,
yeah, I'm sorry, just to ask an online question. They ask, could it be a hematoma causing the hypotension? The answer is no, because the dissection was way proximal. And then, as you said, it wouldn't be going away after time you deflate the balloon. So I think this was very unlikely. But again, thanks very much, Jarrod. Let's hear what happened next.
All right. So by the end of this procedure, this was a tough case. It took me about 2 hours. It took me about a little less than 2 hours. He was fine. He was asymptomatic. His blood pressure was just like, he was almost cut and paste what it was when he rolled into the lab. No symptoms whatsoever. Went ahead and kept him overnight. It was late in the day, or mid-afternoon or so. So kept him overnight. Did well. And it was one of those things that, I kind of kept checking on him every once in a while virtually. This is just another shot. Again, you kind of more appreciate, I think, that bridge segment there. This is what I did. And then about 8 hours later or so, he had some chest pain when having a bowel movement. He was hooked up to telemetry. He got up off the toilet and he collapsed and he was in VFib arrest. And it was refractory. And he died. And that sucks a lot. I'm not even going to pretend like it doesn't. This is one of those things that it was very hard on me, and it still kind of is. But I'm sharing this for a reason, and we can go into the psychology of what this is like different. But this was a tough case, and it seemed to do very well. And then he died of VF, and his wife went an autopsy. And I told her up front, like, I think that the stents probably clotted off. It was really tough to deliver them around there. Maybe they were a little underexpanded going around the bend because I couldn't get IVUS there. And if the stents clotted off, then that was it for him. And this is kind of how it was. So we got an autopsy, and the pathologist called me. It's like, hey, I was reading your note, and I have no idea what you did, but it sounds really hard. Would you come and, do the heart with me? And I said, absolutely, I would love to. Thank you. So this is the guy's heart. I know a lot of us aren't used to looking at this, but this heart is massive. I don't remember the weight off the top of my head, but it was absolutely massive, and it was super floppy. The pathologist picked it up off the table and plopped it down. It was like, an octopus or something. It just plopped, and he just said, "This is an arrhythmic death. This is what it looks like." One of the things I'm going to do, hold on a second here, is I noticed that my blue shift thing is on. So I'm going to take that off. So hopefully you can see this a little better. Is that I immediately noticed this part right here. And I was like, oh my gosh, what is that? Is that an infarct? And he's like, well, I'll show you. So we open it up, we get in there, and you can see that this all here looks sort of hemorrhagic. And this is actually in the territory of the diagonal. And so I'm thinking, well, maybe it is clot, maybe it clotted off. This is actually the SVG that goes to the diagonal, and kind of where that plugs in. So this is more broadly the diagonal territory. Here's me pointing out the SVG. This is in the bottom of the heart. This is a closed saphenous vein with a stent in it that goes to the PDA. And this felt like a tooth. I mean, that's how hard it was. So no wonder we can't get through these things. this was the graft that I coiled. So these are the coils, and that's what fresh thrombus looks like in the coils. And then this is the LED, very small, very diffusely diseased. I mean, it's crazy that we even do angioplasty on these things. And then this is slicing into that area. And what's interesting is that this was all like hemorrhagic. There, we didn't see any clots whatsoever in this entire area. You can see here some of the stents that I placed that are kind of mangled. This is a part, we kind of destroyed it a little bit, but this is part of that subintimal stenting that we often do if we do a dissection reentry strategy. This is the closed LED, and this was hard. This was, like knocking on a rock. And then this was the stent in the subintimal space, and there was no clot in here, but there was a lot of, hemorrhage throughout there. This is some more pathology. So this is the inferior wall, and I'm sort of pointing out what infarct looks like on this. And you can see this is his anterior wall on the other side. Here's that adventitial hemorrhage, but this myocardium is the best myocardium he has. You see it's even still got a nice color to it. It's not all grayed out and stuff. So he didn't actually clot off his stents or infarct. It looked like it was a primary arrhythmic death from his cardiomyopathy. Now, what I can't say for certain is, maybe that repeated ischemic injury, during the procedure, could that have played a role? I mean, I think absolutely could have. And I talked with his wife about that. But the one thing that I am also taking from this is, I never really thought about, because we do more than half of my PCIs involve some sort of dissection-based strategy. I mean, that's just kind of the practice that I run. And I never really thought about what actually happens throughout the median adventitious. We're doing that beyond how it affects me, like how, knuckles react and that sort of thing. But, obviously stents aren't solid, and you're kind of opening things up in there, and it's going to leak through those areas that you make and go into the adventitia. Some of the early autopsy studies that were done after angioplasty in the 80s, one of the mechanisms of how angioplasty works is it creates dissections into the media to help open things up. And so you do get some of this hemorrhage in there. And this, for me, was eye-opening as to the actual mechanisms of how things work, because we don't really see this, and fortunately we don't have the opportunity to see it that often. And I wonder if some of the stuff that we talk about, stretch pain and stuff, is actually patients feeling this adventitial hemorrhage. Yeah, sorry.
Yeah, sorry to that, but just for the people, and actually for me too. So the adventitial hemorrhage is something that happens, right? But doesn't necessarily mean it causes any problem. But this is just the injury pattern of the surrounding tissue, right? But this heals eventually, and that's not a cause of concern. Is that correct?
Correct. Yes, that's correct. Yeah, this is something that happens during our normal stuff that I, had no idea about or didn't think about this. But this is not the cause of his death.
Yeah, so they're asking, is there a myocardial bridge anything to do with all this, or this is unrelated?
This seems to be unrelated. If we do this, and I've actually talked to Akiko about this, Akiko Mahara, the Lord of Ibis. And she can spot, and I'm trying to find it. She's showed me what she's talking about before, but you can actually see on some ibises, and I don't know about OCT, but you can see medial hemorrhage after PCI and after ballooning and stuff, which I've never really seen. To me, it just all looks like calcium and fuzz out there. And I just kind of look how big the hole is,
Well, first of all, this is an amazing case, and thanks for sharing with us, because obviously these cases are hard, but also they're the ones that teach us the most. So it's extremely, and especially when because you never see, as you said, we never see actually what is the result of our procedure. And the assumption we naturally have, everyone, including myself, is that something happens, we did something wrong, right? That's the first step that comes up. So in a way, it's actually a saving grace, so to speak, that the autopsy was performed. Because then now I think you can sleep a little bit better, but also we learn so much. And also you realize that there are many things outside our control that can happen. And, the patient may have a poor outcome, not because of what you did, but because of his underlying disease.
Yeah, I must say, I haven't had a lot of patients get autopsies, stretching back to even, in training and so forth. But I can't say that I've ever regretted a single one because we've learned so much about what did and what didn't happen.
Jarrod, I was having some connection issues there for a second, but is there something that you would have done different based on what you learned, or?
I don't know, honestly. And that's something I've kind of wrestled with. Like, how much of this is just sort of bad luck, that he happened to die from this, or it was influenced by the procedure in a way that I couldn't either predict or change. I don't think that, his pressure would, intermittently tank whenever I would intervene on the diag, but it wasn't for that long at a time. And, do I think about whether or not putting something in to mechanically offload him would have contributed to that? Probably not. And that also introduces some other risk to it. But I really wrestle with this. I think if the stents were clotted off, because that was what I was expecting going into it. I was like, oh man, then, I should have when I had the opportunity, I should have, shoved a guide extension all the way up and around the bend and been more aggressive about using imaging, after stenting that area. But now, on autopsy, the stents seem to be relatively good size and expanded and no clot. So I don't know. My main take home from this for me was just kind of more the mechanisms of what we actually end up doing. But I don't know if anything would have affected the outcome of this one. And for all I know, he was a setup. If you look at that cardiomyopathy, you look at the scar tissue, I mean, EP wanted to wait before they put in a device, but this is a guy that could have also coded at home and nobody would have been surprised.
Perfect. Well, again, this amazing case. Thank you so much. I think in the interest of time, we'll move on to Leah's case. Thanks so much, Raj. And Leah, please go ahead.
All right, thanks, Manas, and thanks for inviting me. I have two cases. We'll see how much we can get through. Let me just minimize that. Okay, so my first one is a 50-year-old gentleman with known ischemic cardiomyopathy, some rheumatoid arthritis that's been off and on managed, diabetes, hypertension, and he was transferred from a smaller outside hospital for further management of his general care. He says for the past few weeks, he's been having some worsening symptoms like orthopnea, dyspnea on insertion, chest pressure, things like that. He's on pretty good goal-directed medical therapy, a beta blocker, Entresto, aldactone, dapagliflozin, diuretic, an aspirin and a statin, and then Humira for his rheumatoid arthritis. So we have got some data on him. So we got a recent echo that showed severe LV dysfunction, low EF, some diastolic dysfunction, even some RV dysfunction, not terrible pressures, but some moderate MR. And then he had a recent right heart cath that showed kind of elevated wedge, low PSAT, and a low cardiac index of 1.8. So we have some diagnostic films, which I'll let them play for a second here. But, I think the thing that points out most to us, he's got occluded LAD. He's got a little bit of a beak into his LAD and then it's completely occluded. He's got this high OM/ramus, kind of 50% disease of the ostium and kind of this big circ, but no real significant disease. And then the LAD fills back here on the same side from these epicardials that are coming off this ramus branch. And then he had kind of a non-selective of his right, but he's got at least moderate severe disease in his mid RTA. So, patient was referred for CABG, doing a CT surgery, just given his age, his comorbidities. He was really frail. He hadn't really been taking care of himself very well, malnutritioned, and had been on long off and on steroid use for rheumatoid arthritis. So they thought he was a pretty high surgical risk. So we plan to bring him back to the lab and percutaneously revascularize him. So I'm just going to go back here, kind of these left-sided images. Honestly, looking at it, we have a nice proximal cap. We can see the distal vessel really well. Doesn't look really that calcified. It's really not that long. So just based on those, I thought an antegrade wire escalation would be appropriate. And then I know we talked about support from before, but I kind of went back and forth a lot about this. Maybe I'll ask Jarrod and Yader what you guys think. Would you use support for this?
What was the hemodynamics again?
Yeah, I'm gonna show you.
So wedge 23.
When I think about support, I mostly think I've kind of transitioned away from the like what the EF is, it seems like I care less about what that is than what the hemodynamics are. Because when I look at this hemodynamic set, what I'm seeing is, you know, what happens during angioplasty is that your EDP starts to rise, you know, within the first couple of beats. And if you're already starting out in a decompensated state with an elevated wedge pressure and moderate MR with kind of a high mean PA, once your EDP starts to rise, your MR is going to get worse and you're going to start dumping back on your RV and that's going to suffer. And so that's kind of what I think about when doing it. That being said, I rarely use support for a CTO because it's kind of already closed and it's really hard to make that worse whenever you're doing it. There are ways, don't take it as a challenge, but that's kind of how I balance it.
I agree that many of these cases we can get by without support. That being said, I do think that the ability to sometimes achieve complete revascularization without sometimes rushing and feel, I think support allows you to sometimes to really achieve complete revascularization without sometimes feeling rushed. We do these cases all the time, but I think sometimes like we got to move fast. We don't want the patient to get ischemic or decompensate. And in a case like this with an index of 1.8, EF 20 to 25%, wedge of 23, I would have a very low bar to use support here.
And the other question is about viability, right? The question is, would you want to get viability? I mean, I know like Jarrod's case, sometimes maybe some myocardium may be dead and maybe help you choose where to go or where not.
Yeah, that's fair. I mean, we didn't get viability, if anything, just because he came in with pretty dramatic symptoms. So I went based off of that, but you know, I think viability would have been definitely reasonable as well.
Dead don't hurt.
So yeah, so I agree with like what you guys both said. I think hemodynamics play a huge part into how I decide whether to use mechanical support or not. And I rarely actually use it for CTO PCI, mostly for what Jarrod said. But in this guy, I did choose to use it. I think it was because he already had that disease in the ramus, and I was worried that when I was fixing the LAD, if the ramus somehow got worse or plaque shifted, he wouldn't tolerate that very well. And so that's kind of what my thinking was for that. So, but whenever I think about putting in support, I always do my own hemodynamics. That's kind of right heart cath before we started. This was our groin shot. I just included this because you can see how slow the flow is in the legs, which I never really enjoy seeing before I start a case. But this looked worse than EF of 20% to me, honestly. But so I was happy I put the Impella in. So here we got dual axis, kind of the usual. That's just a run through into the cap. Just want to make sure we were before we put our microcatheter down. And my fellow actually wired this with a Mongo, and we got in the distal LED pretty easily with that polymer jacketed wire. So from then on, you know, just switch it out for a workhorse wire. We IVIS here. You could tell there wasn't as much calcium, just like we thought on the angiogram. We pre-dilated here, put in the stent here and here, potted. We came back into the left main. I have a hard time believing people can nail the ostium very well. So came into the left main here, potted the left main, re-IVIS, everything looked great, was ready to like call it a day, and then took some final pictures, and that ramus just looked worse to me than it did. Patient was doing fine and there were no changes hemodynamically or on the EKG, but it just looked angiographically worse to me. So we ended up fixing the ramus high OM as well, wired it really easily, ballooned it really easily, and then just gonna ask you guys, like, what would your stent strategy be here? Would you think like culotte, do you get crushed, T-cap?
Well, I guess here the issue is that you already stand it into the main, right? So now if you're going to do a cross, it's going to be a reverse cross. So you have the strut sticking in the vessel in the left main. So probably not the ideal. So either something like a tap, which runs the risk of having a little too much metal sticking into the main, or maybe do a culotte and then do rewiring of the LAD and stent it. Now, the downside of that is you do have some disease on the circumflex ostium too. So you may want to protect that. So if you you may run the risk of opening the LAD and the ramus and then having issues with the circumflex per se. But I'll probably favor culotte. I don't know, Jarrod or Yader, what would you guys do?
I agree.
Let me
in
ask
this.
you this about culotte. Go ahead, Yader.
No. I was just gonna echo the sentiment that at this stage, after you've sent to the main, culotte probably would be the most favorable.
What do you think about the size discrepancy between the ramus and the left main? Because that would be my concern about culotte. I don't do a ton of culotte. Does that bother you?
So the, if you put a 3.5 stent, so the main solutions to this, the one I prefer the most is you get a 3.5, deploy it at a low pressure. So this is probably a 3.0 vessel in the ramus. You get slightly bigger, deploy at low pressure, and then pot it with a 4.0 or whatever, and then you get the best of both worlds, because the 3.5 stents in general go up to 5.75, 6.0, depending on the brand. So if you get a 3.5 in there, you can definitely match the 4.0, 4.5, whatever it is on the main.
See, I think that's a good point to draw out, that of how to appropriately under deploy a stent like that. And when I do it, I just want to, maybe the same thing as you, is when I'm doing something like that, I will watch on fluoro and slowly inflate the balloon until it looks like it's expanded, which is usually below nominal pressure. And then that's when you stop. Is that kind of how you do it as well?
No, I typically go 8 to 10. So I typically go low pressure. But I don't, to be honest, I don't really look. I just go the pressure. I will make sure that it's fully expanded, because I've done it sometimes, especially when you have calcium, that then you can't get anything through because you really didn't deploy the stent properly. So I'm trying to at least expand a little bit, but I will not go past 10 or something. I will keep it low pressure. So even if it's expanded, it's not really high pressure pushing too much.
Yeah, I think I would probably favor more of a tap in this. And the way that I would probably approach that is, and the reason is for the things you mentioned earlier about, the more metal you start putting in that area, and the more that I can see like a cascading effect and impairing your circ, and then how you're going to deal with that and so forth. So my thinking of this would be to try to keep metal out if possible. And I would probably favor more of a tap, but in doing so, this is one where I would inflate a balloon from the left main into LAD and use that as kind of a stopping point as I'm pulling back on the stent to get it to line up a little better there.
Yeah,
because if you look, I mean, that's a huge vessel there, like the left main into LAD. So even if you leave just like the little tip of the strut out there, is not going to be that much of a big a deal. But I think if you do that, like inflate the balloon and stuff, you can kind of tee it up as best you can.
Yeah, well, you guys are mind readers. So I ended up agreeing. I did a T-tap stent. And then here's us kind of lining it up. And here's kind of afterwards. And then patient immediately made the oof sound. The Stolix dropped while on the Impella. EKG changes, and then there's all this haziness now with the osteum of the circ. So this is when I was really, really happy I had that Impella, because I had a few extra seconds to get a wire down that circ. So I opened the stent struts with like a Takura low profile balloon, quickly ballooned it with like a 2.0, and then he felt a lot better. Ivesed it, there was no dissection or anything. It was purely just plaque shift from probably the plaque from the LAD going to ramus, now going to the circ system. So here I was grateful I didn't do a reverse culotte, because then I'd have 3 layers of stent in my left main. So now I here did a reverse culotte. So I had 2 stents in my left main from the LAD and the circ. Rewired my LAD, dilated those stent struts, did some kissing, potted, and here was my final. By the time patient recovered really well and everything, and he felt a lot better. But then I still had to go tackle that right, unfortunately. So, the right was simple, the usual pre-dilate IVUS, stent, post-dilate IVUS. And then these were the post hemodynamics that we got, which were pretty close off to where we started. So when his pressures were doing good, so we were able to wean off the Impella and get that out, and he did really well, and he went home a couple of days later. But my learning from this was that I think I felt good about putting the Impella in ahead of time, but I just felt good about it for the wrong reason. I was really worried about that ramus, but it turned out maybe I should have been more worried about that circ. But I think regardless, I think getting that right heart cath before and after really helped me guide my decision making then, and kind of, I think if his pressures were a little bit better and his index were better, I probably would not have put the Impella in.
Yeah, great case, Leah. Let me jump in. I like one of the comments by one of the participants here. I mean, would anybody have deferred PCI or stenting? I mean, whether you had done a drug-coated balloon, physiology. I mean, one of the comments say here, haptemic 3 flow. I'm just curious, like, Manos and I have been talking about this. I mean, do we underuse physiology in some of these cases to make decisions about some of these things? I'm just curious.
Yeah, I guess your question would be whether to treat the ramus or not. Are you thinking about physiology?
Correct.
Or yeah, I mean, I think that was totally reasonable. I was really hedging the bet that it was like 50%. So I really wasn't planning on going after it until I absolutely had to, until it showed itself during the case. But I think maybe if it hadn't shown itself and he did fine afterwards and it looked the same angiographically, I think it would have been totally reasonable to drop a pressure wire down and see what it is, or IVUS's and see what it is. But I think more objective data is always better. It's better than just our eyes oftentimes.
Yeah,
I'm surprised, honestly, at how many of these actually have normal physiology afterward. Now, this one, I'll be honest, I would have treated just like you did, and I would have been saying very choice words about the circumflex, acting like a circumflex.
Yeah.
But I'm surprised at how often you jail a branch vessel, whether that branch vessel is even the circ or the ramus or a diag or whatever, and then you do physiology afterward, and it turns out it's actually okay. But I think angiographically, it is hard to let those things go.
I agree. I think we underuse it quite a bit, but the challenge is that we're all trying to balance all these issues about procedural efficiency and procedural time versus, get me the pressure wire and try to cross. And these issues, I think there's a real tension in every case that you're trying to balance.
Yeah. Plus, it doesn't matter the brand. Like, all pressure wires kind of suck as wires. And so it's really challenging often to get across stents. And you also, if you've got disease there, you run, a real risk of kind of making things worse.
Yeah, especially with the pressure wire.
It has a nice series. I'm sorry, it has a nice series of correlation of FFR with FFR angio. So in the future, another option would be to not actually put a pressure wire, but do a couple of views and do angiographic FFR. And that might give you the answer without having to recross and recross, which, as you said, can be really challenging in those cases. I'm sorry, Leah, you were saying something.
Yeah, no, I agree. I think the other thing I was going to make is, Yader, you're talking about like procedural time and things like that. If I didn't have an Impella, I probably would have staged maybe the right, but since I already made the commitment and had the access in the groin and had the Impella, I just wanted to do everything at the same time.
Yeah, absolutely. To be honest, it makes sense. Maybe it wouldn't be a need for support the next time, but you did well and the patient was okay and you didn't use much contrast. So I think it's reasonable within the confines. Perfect. And again, I guess because of time, maybe we should go to Jarrod's case because we have only about 15 minutes left. So thank you so much, Leah. Again, phenomenal case, lots of learning points. And those patients with cardiomyopathy and heart failure, I must admit, they're always challenging, especially when they have CTOs, bifurcations. I mean, you had the full spectrum of complexity there. So great way to get by all those problems. And thank you again so much for showing it. So Jarrod, ready to show your case.
Perfect. Well, I'm glad you guys showed some very complex, sophisticated cases, because I'm going to show you something that is more bread and butter, but has been our theme now. I would say not the most instructive case, but what has been transformative in my and our practice, I would say, for the past year. And I thought I would just show this because it's really, frankly, what has been the most instructive to myself and I think many of us in our practice for the past year or two. So 84-year-old female came with atrial fibrillation, RBR, dynamic troponin increase, non-STEMI, bread and butter case. Because of the AFib, I guess this was perceived to be maybe a little bit more of a type 2 myocardial infarction, and maybe for that reason the patient was not referred first to the cath lab and an invasive approach, but rather was stratified for a CT, which I think it's an acceptable strategy in some of these patients that don't have like a definite classical ACS. And again, this is what I would say has been the theme of our practice. So the this is where the crux, of course, I think, and what the lesson has been for us over the past year is that the traditional approach is that we would look at the CT, and the CT here says, there's a severe middle AD stenosis, 70%. And I would frankly tell you that 2-3 years ago, to me, this is okay. I mean, what there else is to say. Bring the patient to the cath lab and we'll figure out what we're dealing with. And that's probably what I would predict 9 out of 10 interventionalists or more do every case. But what we've learned, and I think what has been instructive to us, is that it takes 1 second to really get more information about these cases. And I want to show you this image, and then I want to pause and get the opinion about the group here, because this is something that we were not doing, frankly, a couple of years ago. And we learned, but that by doing a simple click in any radiology software without advanced CT training, you can pretty much get this image called a MIP. Maximum intensity projection, and pretty much you click it, it gives you a 3D model reconstruction of all the vessels, particularly if you have a good scan, and it tells you what the anatomy is. I want to pause here and ask the group, what do they think about this model? Is that useful? Is this not useful? And pretty much just from this, what do you think about this case?
I'm just going to say that, I think a second for you is different than a second for me. And dealing with CTs, I think Yader seconds are it's somewhere between pico and nano maybe, because I do I'm showing my age. I know I've got more grays now, but I was not raised in the age of routine CTs and stuff like that. And so I'm still not used to looking at these. I think they're a very valuable tool and they're very complementary. But for me personally, I go down with the people that actually know what they're looking at. And I've found it very helpful and rewarding. To me, I can see this one area that looks kind of, I would say, pretty tight. It keeps spinning, so but yeah, there's one area that looks pretty dang tight, and that's what I can say from the CT.
Leah, what do you think?
Yeah, I would agree. Oftentimes, sometimes I get CTs on my CTO patients when I'm not sure the course of the vessel or where the cap is, things like that. But I often have some of our experts kind of squeeze out the information for me, and they take these really nice pictures and send it to me. And I'm like, okay, great. This is where I'm going to stick my wire. So I agree. I'm not nearly as good at reading these as you are, but I agree. There's something very tight there.
So perfect. So
if I can say for a second, actually, I've been fortunate because Yader has brainwashed me for quite some time now. So this thing, I can tell you, it's like looking at CTOs. The first few months, it's a little, it's a little weird. You're like, what the heck? I'm wasting my time. It takes you 10 minutes to get to that view, and then you don't know what you're looking at. So what I would do is just forget it, just go down and look at it with John Lesser and Joao Cavalcante and Victor Cheng, the whole CT group. But now, the funny thing is after you do this case after case after case, actually it does get much more straightforward. And this actually is automated. You don't have to do anything. You just click a button and the machine does all these models. So all you have to do is just spin it and look at it. And the imagers don't look at this. The imagers say this is not very accurate. But for our purposes, tells you the origin of the vessel, tells you the size of the vessel, tells you, it's the calcium, it's a beautiful image and very simple to get.
And again, that's the reason I'm showing this thing here, because this has been what has been the most instructive, I would say, to us in our practice, as Monica is alluding, for the past year. Because I was with you guys a couple of years ago. I was like, let's just go to the lab. But then this is free information that may help us. In this case, it's pretty straightforward middle AD lesion that anybody can do. But there are cases that are not. And what we've learned is that it is truly one click, as Monica alluded, because it's automated. You just go to the software, choose click on MIP, and this image gets reconstructed. Particularly if there's a good quality CT, would really tell you the right's normal, the circ's normal, left main is fine, and there's a focal middle AD lesion, and that already tells you a lot of information. So again, LAD disease. This is I'll switch to another view that I'll get the opinion from the group, but briefly here, this is how you can choose your guide. And so we looked at the CTs and pretty much we say, okay, the right's coming a little bit anterior. I don't need to go and fumble with a JR catheter. I know I probably need an AL1 because it's an anterior takeoff. And same for the guide. I do not need a diagnostic angiography. I don't need a JL. I already know from the CT, and that's the value for it, that there's a focal middle AD lesion. So therefore, you don't need to potentially waste unnecessary additional pictures, contrast, radiation. You know where the problem is. You can pretty much just go to the ostium of the left coronary system, get a length, and know that this is a 4.0, and probably, get me a EBU 4.0 guide and get going. So let me show you this picture and pause one more time. So this is a multi-planar reconstruction. Again, I know I'm pushing the group a little bit here since not everybody looks at the CT, but again, this is what we have learned, and it's like shifting this, because again, I am not a CT certified reader, and I do not read this professionally. I read this as an interventional cardiologist to inform my procedures. So this is just one click in the LAD, and just focus on this panel here in the middle that I'm clicking play here, that one. So the disease is clearly in the middle AD. I'm gonna let this run. What do you guys find helpful here? I mean, there's clearly some branches, there's some length of disease. Is this a focal stent there to there? Is this a long stent from here to there? Maybe I'll pause. Jarrod, what do you think? I'll keep playing this.
At this point, I'll think whatever you tell me to think. This is just amazing. For me, I put, I'm still like, I put a wire down there. I'll put the truth machine down the vessel, that's IVUS, and then just kind of go with that. But this is really intriguing to me to look at this longitudinal view, because you can see distally, it looks relatively disease-free. But proximally, there's disease all the way back to, like, I guess that maybe the ostium, or that's the circ coming off in that second window.
Correct,
the
correct,
curvy thing's
correct.
kind of bending with me. I don't know
Correct.
if I'm taking
This
mind-altering drugs.
is right there where my mouse is. That's the circ, and right over here, I would say that the most important value, and again, this is one click, is that right there, there's a lesion and that there's a diagonal coming off it. And again, I know, I was with all of you. I know that we can figure this out in the lab. But already, let's say you want to protect this, you want already an EBU4, there's a lesion, and you can already up front say, I want 2 wires. I want to protect this wire edge. So you're already asking your equipment before you get to the lab, and you already get a sense of where things are. I'll switch for this one and ask this one to Leah. So this is now pretty much, we do this all the time. Why have we adopted this, and why this is now something that we think it's, helpful, is because, I think probably all of us, I want to speak for us here in the call, and maybe a lot of the participants, we use a lot of IVUS OCT. So this shouldn't be alien, right? This is like when we're doing IVUS or OCT, we're doing pullbacks, we same thing, we'll see a longitudinal pullback on IVUS or OCT. So with the CT is the same thing. You get this straight multiplanar reconstruction and you just pull it back. And you see the panel here on the bottom left. It's pretty much the pullback of the vessel, same thing as we would do with like IVUS or OCT. And right there, you see the stenosis, and then you go back to normal, and then you go and see the bifurcation right there in the diagonal, and you keep seeing some disease. So my question, maybe Leah, I know that maybe I don't know whether you have any experience with CT or not, but is this something that you balloon, or thinking a atherectomy? What are your thoughts here, particularly from a plaque modification perspective?
I'm guessing I don't see any super bright stuff to make me think there's a lot of calcium. So my guess is just probably like a regular balloon and see how it gives and go from there. But I'm not anticipating a lot of calcium modification.
Agree. Perfect. Right? So again, this is a bifurcation. There's a diagonal. There's nothing bright. We all know how calcium looks. There's nothing bright. So it's a super soft lesion. This is with CT. Something that we've been using here is on the right, is that now there's a bunch of very automated systems that have these 3D models. This is one from a company called Clearly, that pretty much now you make it even way easier, because again, we are not CT trained, and that's the reason. This is literally something that we use regularly, because we are not level 2, level 3 CT readers. So if I don't know where I am, I just look at this 3D models that I think we're comfortable with this, and they're like right there in the LAD, there's this yellow sort of like circle, yellow, as you can see on top, it's non-calcified, it's a super soft lesion. So as you can see there very quickly, and again, it takes, I would say, the first time you do this takes 30, 45 minutes, then you go to 25, then you go to 20. Preparing a case like this, I would say now takes probably less than 10 minutes to quickly know what you want before a case. So now you know you need an EBU4, you have a bifurcation, you probably need a couple of wires, soft lesion, non-compliant balloon, and based on, before I skip this one, you probably know you want to prepare this with a 2.5 balloon. You can put up together your 2 plans for the sake of time, and here you can pretty much say you want what your angles are. You're on an areocranial. what your length is, and you can prepare the options. So here from the CT, we know one option is to stent distal to the diagonal, 16 millimeters with an area of 30-30, or we can cover all the way to the proximal LAD with a 34 millimeter, and we already know our balloons, our angles, our length. This is something that I would submit we interventionalists need to get used to. There's no need for diagnostic angiography. There's no need for more radiation or contrast. There's no need for the traditional four corners pictures. You know the angle, you take the picture, you get the case done in 10 minutes. This is what we integrate with physiology, virtual physiology. And the reason I want to show this is because this is also instructive to myself and our practice. Not long ago, I used to think about FFRCT, and including many of us think in the cath lab as FFR or IFR or non-hyperpreservation as a binary pregnancy test. It's not, right? It's really a continuum. And if you drop the information, you can really understand the phenotype. But the reason this applies to us in the cath lab is because of this. And this is, to be honest, what led us in this journey of what we call CT-guided PCI, is that now we can pretty much do virtual PCI. So as you can see, you can now use these tools. This is from a company called HeartFlow that has a virtual PCI planner that pretty much you just open an iPad or even an app in your phone, and now you drop in those 3D models, you drop stents, so that what they're doing is they're pretty much telling you what would the predicted FFR be depending on what stent length you want to implant, and you can implant whatever you want. And you can also simulate two stent techniques. So here, for example, this hypothetical, I don't know that any of you would do this, but if you drop a 22 millimeter stent, you would get a suboptimal FFR of 0.77. And if you drop a 38 millimeter stent from here to here, you get an optimal of 0.86. So again, you can really dot a lot of PCI planning. This is what we found, consistent with what we were expecting. So I think it provides a nice a correlation of what we're expecting from the CT. But again, this is what I'm showing up front. First picture, you're ready with the guide. You already know what you're dealing with. We're doing a lot of physiology because we want to understand how to move forward in this field. And I totally agree with Jarrod, because we're not there yet in like, oh, like it's a full CT. We really think this tool is complementary. It's free information. It's there. It helped us plan our procedure. But we're still trying to, particularly vessel size, I think it's an issue that we need to understand how to figure out better. So we use, at least in our practice, we use broadly intravascular imaging, whether that's IRIS or OCT, now for the vessel sizing and the post-PCI assessment. Again, this PCI is done in just a few minutes. You already know, as you know from the CT, what you would do. Maybe I'll pause here and whether people would have done something differently, but this is pretty much from everything that we planned is pretty much a straightforward provisional PCI to diagonal, protecting the diagonal, and based on our plan from the CT, we know that the most optimal physiological result is from a 38 millimeter stent. I don't know whether people would have placed as a long stent just looking at the angiogram. Thoughts, comments?
Yeah, I don't know. The way I look at it, Jarrod, I think it's actually looks worse on the angiogram than I was expecting on the CT. It looked to me like there was a tight lesion after the diagonal, and the rest was borderline. But on the angiogram, actually, it was more severe than I thought on the proximal. But nevertheless, I think based on the FFRCT planning, I would have put a longer stent anyway, so that fits right in what I would have done based on the initial pictures that we had shown us before.
I agree. And again, maybe I'll just go back to this picture because I think this is part, again, of what has been instructive and an ongoing educational experience for us, is that clearly you see that in the CT right there, that proximal disease there. So I think this cases go both ways. Sometimes it might be as an additional added work that we're like, oh, do we really need to do this for it's a straightforward PCI? But sometimes I think we all know that angiograms, it's a luminogram, and sometimes there's way more things that we're not really appreciating, particularly on the two-dimensional luminogram, particularly with induced intravascular imaging. So sometimes it's at least just raising awareness. Hey, there's some disease there. Maybe I need to think about covering it. And in this case, whether that's physiology, virtual PCI, or intravascular imaging, pretty much in 1 second tells you need to go long. We do a 3 or 38. We do post-PCI physiology. We do this, again, I do a lot of physiology in my practice. I'll pause here again whether people do post-PCI physiology, but here the only observation that I want to highlight is that as we're learning how to integrate these tools, you can see that the predicted physiology that we were aiming to achieve based on the best potential result according to this model was 0.86 The post-PCI physiology is 0.87. Anybody here is doing post-PCI physiology of any sort, whether that's angiographic or pressure wire or any physiology?
I'm not, to be honest. Just one reason is like, even if I do physiology with a pressure wire before, I don't work on that wire. I always put down a regular workhorse wire to work on. So for me, it'd be putting down an additional wire, and I feel like that carries risk too. So as long as I have a good angiographic result and a good IBRIS result, I'm happy.
Yeah, I would say that if I end up working over the pressure wire, then I'll routinely check it afterward. And if I don't, like if it looks like just, you know, because they're not really good wires, as guide wires. What I will do is a pullback before I take the wire out, just to make sure that the disease is where I think it is. That was something that I got from, was it the Sweetheart, that showed that about 20% miss focal lesions that just by angiography alone, when they stent after doing a pressure wire, they actually end up missing what it is. But you know, it's not really you know, much to it, I guess.
I know we're almost over time, but I'll jump on that comment because I think that's important, because again, this is a super straightforward case, which is the whole purpose to illustrate the concepts with not a overtly complex case. But your point is, I think it's important. Here you see that the predicted FFR is 0.86. So the value of what exactly you're saying you want to do the post-PCI physiology is because you already know before starting the case that this is your target. And if for whatever reason you end up and your FFR is 0.75, you know there's something wrong. Your stent is underexpanded. There's something distal or proximal to the stent. There's geographic miss. So it's an area of, that I think is their ongoing debate. But in this particular value, particularly with some of the CT work that we're doing, is that you know where the target is. So if you check it, you can confirm it. To wrap it up, I will say that, you know, we've been doing this and there's a lot of opportunities. There's actually a randomized trial that we're part of. I think right now we're the only active site in the US that is looking at CT-guided PCI versus IBRIS-guided PCI. I'll let Manos maybe add, since he's also very involved with this, particularly with the CTO. So we're doing a lot of this work. The case that I picked was non-CTO, but we've also done this in CTO, and arguably, I mean, your CTO operators, I'll be interested, but in your opinion, but actually where we have randomized data that we can improve procedural successes for CTO PCI guidance. So there's actually an excellent precedent for using this, and now this trial is trying to expand this for all PCI. So with that, I'll wrap up and pretty much say that for us, for myself, the most instructive theme has been pretty much integrating this existent information from all the cases that we're referring to the cath lab with CT, and shifting from we're just going to cath these patients to let's just quickly take a look at the CT and see whether that can help us with our procedural planning. Thank you, guys.
Perfect. Thanks, Yader. Again, I think there's a lot of work going on, and thanks to what you've done and other people are doing on the area, people are getting more and more familiar. And then I believe in a few years, I don't know how many, but in a few years, we will be actually planning PCI based solely on CT. There will be, and already it's happening. Some of the people actually are being sent for CT or PCI based on the CT alone. And I suspect this number is only going to increase. But overall, again, thank you, everyone. It was an amazing evening. We had a lot of learning in terms of people with cardiomyopathy, about how to do the reverse card through bypass grafts, how autopsy can be extremely useful, how hemodynamic support can bail you out when things don't go well, and how CT guidance can help with PCI. But thank you again all so much for tonight. I would like to thank all the people who participated in the podcast, and actually this will be also available online to see, and also our sponsors, Abbott, Medtronic, and Shockwave. So thanks again, everyone, and have a wonderful night.